Shukran jazilan for inviting me. I was thinking, if I could have my first slide, please, about my last trip to Saudi Arabia. Here's the program from 2020. And the last day of that meeting was the start of the pandemic, and I was on the last flight that was received into the US before it got closed. So I'm so happy to be back. You can imagine, like 4 years, how would you feel like Eid al-Fitr after 4 Ramadans in a row, combined? So I really, really appreciate it. And we have so much to talk about. Look, there you guys are. So sweet. So that's why I'm going to take a lot of pictures today, because what if there's another pandemic tomorrow? You don't know. So how long we're going to go. Meanwhile, I have 2 grandchildren since I saw you last. This is my daughter here in the front, and my son-in-law, and 2-year-old Alina, and 6-month-old Emmett. So lots can happen during one small pandemic, right? So I'm very glad to be back. So I have a question for you guys. What is the most important prognostic factor for anyone with cancer? Age. Oh, therapy. Thank you. Therapy, exactly. And how do I know? I'll show you how I know. There's many ways to know. But this is just acute lymphoblastic leukemia in children. And from the 60s to the 70s to the 80s, you see curve A to curve B to curve C, how things improved greatly decade after decade. And what changed? These were children coming to one hospital, St. Jude Children's Research Hospital in Memphis, Tennessee, where I live right now. And they were the same number of Philadelphia positive, Philadelphia negative, the same CNS positive, CNS negative, same number of teenagers versus younger children versus babies. So every prognostic factor you can think of was the same over the decades. And yet the cure rate went from 10% to 90% over this period. So what changed? It wasn't the patients, it was the treatment. So we don't think about that, because when we think of a prognostic factor, we think of, I'm going to give this patient the best thing I can, and then the prognostic factor is what else is left after I give the best treatment. So we're assuming the best treatment, like Munzer showed. If you're giving azacitidine, your result is worse, right? Because you gave a worse treatment when you could have added some other things to it. So the most important prognostic factor is the treatment. And here's the most recent study that came out of St. Jude that had amazing CNS control. On the bottom, this is CNS relapse. So you can't see that curve because it's like hugging the bottom line, and it's 1.5% incidence of CNS relapse. So my job was to talk about controlling the CNS in ALL, and both children and adults can benefit from this strategy. So this is relevant for all of us, and this is a problem that can be controlled. We can eliminate CNS relapse. So we should never have to have a lecture of how to manage CNS relapse. The answer is, don't let it happen, right? So maybe your colleague could send you the patient, so that's the only way you could have a CNS relapse study. So what happened in St. Jude did some crazy things for this total 16 protocol. 30 weeks of asparaginase. Imagine giving pegasparaginase on week 1, 3, 5, 7 for 30 weeks. So that's pretty rough. And that also is the strategy. We actually copied it from Dana-Farber. So they're giving 30 weeks of asparaginase to people up to age 55 years old. But above 55 is difficult, and even below 55 for people who are obese, which is very common in the US, people who drink too much alcohol, which is too common. So there's reasons why you can't get away with this in adults, especially older adults. Luckily, we have Taiwan study. What did Taiwan do for us? They studied not doing the first LP when the patient walks in the door. And everybody knows when a patient walks in the door with new acute leukemia, it's always who's going to do this first lumbar puncture, because they're coagulopathic, they have high white count. If you have a traumatic lumbar puncture, you're introducing leukemia into the spinal fluid. So you really don't want to do an LP on day 1. And if you have to do it, then it should be the most experienced person you can find. I don't mean the oldest, I don't mean the most senior, I mean the most experienced. Sometimes it's a resident, sometimes it's the old guys. At our hospital, it's Dr. Ching Han Pui. He's 68 now, and he still has 0 red cells. Every single time, 0 red cells. Because whenever I have 5 red cells, I used to think, oh, it's just bad luck. Nobody can control 5 red cells. And then I, as a fellow, studied 5,000 lumbar punctures at St. Jude, and his was always 0, 0, 0, 0, because I sorted it by the name of the person who did it, and saw so many zeros, so I thought maybe it's not luck, maybe it's skill, and who knew? So these geniuses in Taiwan, they waited till day 10 of induction therapy, 4-drug induction. So Japanese had studied twice delayed lumbar puncture, day 8. They gave a week of prednisone, and then day 8 did the first lumbar puncture. And it worked great. And what did everybody say to the Japanese? Are you crazy? How will you know if the patient is CNS positive? If you give a week of prednisone, maybe they were CNS 3 when they showed up, but now they're CNS 1 a week later because you sterilized the CSF. Sure enough, they did sterilize the CSF, but the patients didn't relapse. So it looks like we've been doing the wrong thing since childhood, which is to do a lumbar puncture in somebody with active circulating blasts. So in Taiwan, they used the most mild protocol imaginable compared to the St. Jude protocol. And look at their CNS relapse right there, right along the floor. They had 0 isolated CNS relapses, like none, and 2 combined CNS relapses. And for me, if it's combined, it doesn't really matter because the hard part there is the bone marrow, not the CNS. So isolated CNS relapse is really what we're going for, and they managed to eliminate it without 30 weeks of asparaginase. Adults and children, just by delaying the first lumbar puncture and not introducing blasts. So I have 5 messages for you today between this talk and the next talk, two speeches later. And these are 5 things that I hope tonight, if you go see a patient tonight, I hope you won't do a lumbar puncture if they're newly diagnosed. I hope you'll wait till day 8 at least, but really wait till they clear their circulating blasts. So these are things we can do today, right now, without money, without anything. Just read this paper. Go watch it on YouTube. Thank you, Ahmed, for this advertisement. I like to listen to Bon Jovi on my way to work, but you know, maybe I could do Bon Jovi on the way and YouTube on the way back, right? Because we can all up our game. And there's a whole hour of lecture about this, so I'm not going to have to go into it because I don't have to, because you can just go there and download the whole thing. And if you want a whole hour about just spinal taps, you could do that. You know, makes a great entertainment on your way back home. So here are 3 curves here, the low curve, the middle curve, and the high curve. So the orange curve is if you inject chemotherapy right into the ventricle, like an Ommaya reservoir. So that's great. You get 100%, you get 100% orange curve because you're putting it right there and then you're measuring it in the same place. So that's 100%. If you do a lumbar puncture and let the patient, after you finish the lumbar puncture, the patient say, go home, have a nice day. They get up and they walk out of there. Only 1% of that lumbar puncture will reach the brain. Why? Because the CNS is made in the brain and diffuses down into the spine. So when we do a lumbar puncture, it's going against the flow. So it's like a salmon swimming upstream, trying to make it to the brain, and the flow is against it. Then if you let the patient stand up, now you've got gravity plus flow, and only 1% reaches. The purple there is if you force the patient to lie flat for 1 hour. So, number 1 thing to remember, no lumbar puncture till day 8 or day 10 or whenever they've cleared their circulating blasts. Number 2, the patient lies flat for 1 hour. It's even better if you can do Trendelenburg. My dream is to have boots where you can hang the patient by their feet. And so you do the lumbar puncture, you hang them, slide them down, take the next one. And they can just sit there for 1 hour. Because what if we could get 30% here, just by gravity? No money, just gravity. Wouldn't it be great if, like, we're doing 20 lumbar punctures in the high-risk ALL, you know, children with high-risk ALL, 20. What if we could do 10 if they just hung like this, and we got twice the value out of each lumbar puncture? Sounds really nice. So here's the bad news. It takes that blue level is the average cytotoxic level needed for acute lymphoblastic leukemia. And when I say average, half the people are above average, half are below average. So half of the leukemia cells require a higher level to kill them, half require a lower level. And so that's what average means, right? So if you say, oh, we're all above average, no, that's not math, right? It's a beautiful idea, but it's not going to happen. So we got to get to that level of 1 in half the patients. We got to get higher in half the patients. How are you going to get higher? So I was very glad to share the car with Ala from Iraq, and he said, hey, we're giving IT and systemic high-dose methotrexate, both. And he gets criticism from his colleagues because they say, no, just pick IT or systemic, one or the other. But it turns out IT almost gets us there, and systemic almost gets us there. Here's the problem with IT. Also, I have conveniently put this pictures and many others into your abstract book, so I'm sorry this book is so heavy. It's my fault. Also, I have to raise my my flag to Noor because the 400 reminder emails, I appreciated every single one of them to get the abstracts in. Dear colleague, please send it in. If I were sending the 400th reminder, I could not have been like Noor. So I admire, yeah, bravo. So it's a reminder is great, and the character, wow, double benefit. So this is what happens if you just do IT. It doesn't penetrate very deeply. So imagine you have a primary CNS lymphoma. It's a parenchymal disease sitting inside the brain. IT is not going to get there, mostly. So parenchymal lymphoma, that's why we use high-dose methotrexate for primary CNS. It penetrates everywhere. So when you do the two together, it's fantastic. When your colleagues doubt you, doubt your wisdom, they say that guy was crazy, it's okay. Just come here to the high-dose methotrexate Research and Care Network. Every single Monday, 5 p.m. Jeddah time, we're meeting to discuss methotrexate issues. And what's great is this guy, Archie Blyer, he's just turned 81 years old, and he wakes up at 6 a.m. every single Monday to come to this meeting because he lives in Oregon, West Coast. So 6 a.m. for him, 5 p.m. for you. I say he's making the greater sacrifice. So please come. He's half of what I'm about to show you, I learned from him in the past year. There he is in the corner there. See how it's still dark up there in the corner. And he did the phase 1 study of high-dose methotrexate. So he practically invented high-dose methotrexate. And you know how it's nice when you meet a smart person? But sometimes when they're young and smart, it doesn't have the same effect because they're obnoxious. And they lack experience. Imagine you've been smart for 81 years. You know, what that brings to the world, what that brings to your colleagues who show up on Monday at 5 p.m. Jeddah time. And his study, look at this, I don't know if my pointer, here we go. Can you guys see that in the back? This green dot up here? Oh, see, they're all just falling asleep. Anyway, there's dose levels here. And look at the top dose level. 88 grams per meter squared over 42 hours. So when we complain, oh, I don't want to give 3.5 grams, I think 1.5 is safer. Back then, they had hair on their chest. Even the women, it was really very, very brave. They went to 88 grams. So you think you're going to see toxic death like crazy. You know what the dose-limiting toxicity was? This was hilarious because you can't get this, you can't read this anywhere. You have to talk to Archie. The dose-limiting toxicity, they didn't reach it. At 88 grams, they ran out of methotrexate in the whole United States. So they couldn't keep going. They couldn't go any higher. They could barely stay at 88 grams because of lack of methotrexate. And there wasn't a DLT sufficient to stop. So we just called it at 88. And so you should go listen to this. He presented this 2 years ago. I probably heard this 5 times using the CAR strategy. So here's what's nice is, here's the steady state on the horizontal is the blood level, the vertical is the CSF level. And notice it's a log scale here, so we're going from 0.1 to 1. So when you go 1 bar up here, it's 10-fold more CNS penetration. And what did I tell you? 1 is what we're going for here, so trying to get above 1. So when we give 2.5 grams IV, high-dose methotrexate, it's right here. When we give 5 grams, it's right here. So a lot of times we're going to be below where we need to be to treat a CNS ALL. So, yeah, I always count on not having a pointer. And if you give 33.6 grams, which is the best high dose for CNS, then you actually get a level of 36 micromolar in the CSF. A level of 1 is good. A level of 36, trust me, this will kill every leukemia very, very well. How do I know? Archie Blyer, they did a randomized trial, 33 grams versus 8 grams in newly diagnosed children with ALL. And what did they learn? They learned a lot. Basically, the event-free survival was the same. And back in the day, so imagine this, you can give 8 grams of high dose plus IT plus CNS radiation, or 33 grams of high dose. Equal results. Back then, radiation was cheap and IT was cheap. Now we do IT under general anesthesia, so it's a real pain in the neck. And radiation is horribly expensive, and now we know the late effects of radiation are terrible in children. They're not that great in adults when you radiate the brain, whole brain radiation. So back in the day, they said, well, 8 grams is cheaper than 33 grams, so we prefer 8 grams. So 33 grams of methotrexate was left behind for financial reasons. And every single financial reason is reversed now. But it's not coming back. Why is it not coming back? Because none of us knew about it, right? Who knew about 33 grams? Who did not know? I have to assess the comatose rate here. Okay. You guys, how are you doing back there? You didn't know. I know you didn't know. None of us knew, right? I read a lot about high-dose methotrexate. I go every Monday to a whole meeting just about this one medicine. I didn't know till last year when Archie presented it. But 33 grams in patients who had had like 5 relapses. So here's a relapse study of ALL. 4th, 5th, 6th relapse. Every patient had a cranioradiation. Every patient had dozens, some had hundreds of IT therapy. High-dose methotrexate, high-dose cytarabine, everything. So what did they do to these poor 20 patients? Not poor. They were poor patients before they got to this study. They got 33 grams. And here's the CSF white count here, anywhere from 10, 50, 100, here's a 10,000. So the highest one was like 5,000, 2,000, 1,000. These were bad, bad relapses. Their whole brain was caked with leptomeningeal disease, spinal fluid, rich in leukemic blasts. They got 33 grams, and that's before, and that green circle down there is after one course. 12 patients had a CR. One course. So then you think, you know, we always talk about, oh, I'll give IT thiotepa, I'll try every kind of trick. It turns out we had the answer right here in our hands from 1987 is when they published this. So who goes back to read 1987, right? Even the YouTube doesn't go back that far, right? So you got to actually open a journal and read it. Not going to happen. Luckily, JCO 2006 published the long-term effects of this study, and it turns out the kids who got 33 grams, the ones in the red box, had better brain function, better school performance, better everything related to the CNS. So it looks like 33 grams is not only equally effective, it's less toxic, long-term and short-term. So what's the most important prognostic factor? You guys nailed it from the start, treatment. And here's something about treatment that is new data. So remember, you're going to have to remember 5 things. And somebody told me you can't remember 3 things, so you've got to stick to 2. You were going to stretch your brain today. So number 1, no lumbar puncture on day 1. Number 2, lumbar puncture day 10, day 15, doesn't matter, just not day 1. Number 2, anybody? Thank goodness, thank you. Trendelenburg, or if you can hang them up, you know, be great. Number 3, urine alkalinization. And so here's a kidney on high-dose methotrexate. You got to be careful because you see the yellow there, yellow. All the yellow is not supposed to be there. That's crystallized methotrexate. So you do not want to diagnose acute kidney injury by autopsy, right? This is terrible. It's very sensitive, very specific, but not recommended for diagnosis. Luckily, this was an animal study. So this is the kidney of an animal, and we were intentionally causing kidney failure in these animals. So in humans, though, we learned that one way to prevent this problem is to know when they have delayed elimination. So in green here is the 95% confidence interval. The black line is the median, so half are above it, half are below it. That's what the median is. And the green is the 95% of what's normal. So if you see your patient in the blue here, this is free, resonancehealth.org, which is my organization. So everything I tell you is going to be free. If you see Resonance, you know it's free. So you should be using it for your patient. So you just type in your methotrexate levels and it tells you if it's above 2 standard deviations. So the red line on top is 2 standard deviations. So that's intervention territory. So don't let a patient slip by because none of us with our brain can calculate 2 standard deviations because you have to feed in the age, the creatinine, all the details of the patient, the dose, the infusion schedule. And then we measured acute kidney injury. I'm going to go back here for the photo. Go ahead. Good. And it turns out, look at the bottom, courses with bad urine pH, double the rate of acute kidney injury if the pH dropped below 7 at any point in the first 24 hours. So I thought it was bad when we saw, oh, the pH is 6, give them some bicarb. I didn't know it was really bad, really bad. So doubling the rate of AKI, that's bad. And I want to remind you of one thing that makes the urine acidic, and that is cola beverages. So I was just in Jordan. After 4 years of not coming here, I got to go to Medina last week and had a 2-day break in Jordan and then came back. So in Jordan, it was great because you go to the restaurant and my friend drinks a lot of Coke. So he asked for a Coke. They say no. He says Pepsi. No. Because of Palestine, no Jordanian will drink an American beverage. So I like that. Luckily, there's an Iraqi cola. So thank you, because he could still have his unhealthy sugar. But please, if your patient is on methotrexate, they should neither drink Coke, nor Pepsi, nor Iraqi cola, nor any brown cola. Why? Because the pH of those colas is 2.5. The stomach is like 1 or 2. So the pH is supremely acidic. And in Egypt, they published this a case report where they showed each time the patient was drinking a cola, they had to give bicarb bolus to make up for it. So please just take away the cola and don't try to bicarb your way through it because it's ridiculous. So the patient can drink water, milk, yogurt beverages. There's so many things they can drink, but colas no. And certain juices, apple juice, 2.7 or something like that. pH of less than 3, apple juice, orange juice. So it's surprising. So watch the drinks. Water is great. Urine pH of 5 versus 6 versus 7. The green box is how much acid. So remember, pH is a log scale, so when your pH drops from 7 to 6, you have 10 times more acid. From 6 to 5, 10 times more acid. So a pH of 5 is an absolute disaster in high-dose methotrexate. But a pH of 6 is also really bad, doubles the risk of acute kidney injury. Doubles. So the third thing to remember, no Coke, and keep the urine alkaline. So now we have to modify. It's not just treatment, it's treatment and supportive care. And so I got to wrap up here, and so the last two things are in the next lecture. But you don't have to worry. I used to worry so much, try to put in 400 slides and talk in 20 minutes, 400 slides. No, just click on residencehealth.org/networks, and you can see a lecture like this or better. It'll be by Archie, by really, really good people. So I want to emphasize also this mtxpk.org, because you can actually go there and find out who needs a special intervention. And I'm going to skip to the special intervention since I heard that glucarpidase is now approved in the kingdom. So congratulations on that. How are you going to use your glucarpidase? I'll show you here. And these slides are available so you can download them, but that's why I don't feel like I have to even talk about them. No time. So here is a patient getting high dose who needs glucarpidase. And in the red is every screw up that happened to these patients. Either they didn't get enough fluids, or they didn't get enough leucovorin, or they didn't get glucarpidase on time. And if you're in the red, 3 strikes, 5 out of the 7 patients died who had 3 strikes. It was basically bicarb, leucovorin, and glucarpidase were the 3 strikes. So when you're using glucarpidase, I want you to actually read this paper, but half of it no longer applies. This paper is only 10 years old, and already I have to renounce it. Which is sad because you spend a lot of time writing these things and then to renounce it 10 years later. Glucarpidase will take that methotrexate level down in 5, 10, 15 minutes. So if your methotrexate level is too high, you give 1 dose of glucarpidase, it will go to 0. Just like resburicase for uric acid, same thing. And there's the glucarpidase out there chopping the methotrexate. But after you chop the methotrexate goes down in the blood. In the blood. It's still in the cell. So after you finish, you got to give a bunch of leucovorin. See all the purple down there? That's leucovorin, leucovorin, leucovorin. So first you get rid of the methotrexate from the blood. Then you give leucovorin to rescue the cell. But leucovorin enters the cell by the same transporter is for leucovorin and methotrexate. And we're out of here. So have a nice day.